Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
It's associated with so much pain and agony if you get the shingles, and it's very common after the age of 50 because we've all been exposed to it, but it becomes reactivated. So they remind everybody to get their 2 shingles shot. There's a new vaccine that is available. So just a reminder. So you get your other shots, which you will be doing if you haven't already, because October is the month by which you should get all your vaccines done. So I just thought I'd remind you, since if you're over 50, shingles coming back is so painful that you get many reminders to get your 2 shingle shots. Okay.
I don't have enough arms. I don't have enough arms for all these shots.
Well, you can always use your butt. It's bigger than your arms.
That's true.
Yeah. So I guess we can get started. One of the interesting things I was looking at was also an article on how Asian Americans also have same kind of racism we have, and it may affect their health as well as it affects ours, because being different has its consequences. If you, because people see people, when they see people who are different, they are uncomfortable. So, so all people who don't look exactly like the majority do have the similar consequences there. As you recall, in your history books, you read about the Asian Americans being put in prison during the World War. And so just a reminder that we're not alone in our, of course, the Jewish people have a particular interest in those kinds of things. But anyway. Okay, John, I guess we can begin the.
John Tatum, you need to make tech support a co-host. I couldn't do it for some reason. I won't be able to share.
Another interesting fact while we're waiting is that nearly 40% of our children's children don't have primary care doctors. So the question is, who is actually taking care of them? And perhaps no one is. Maybe they don't go to the doctors like they should. So.
All right, here we go.
Okay, this is an interesting article. It's interesting you put it first. This is kind of a revolution that has occurred in transplantation. The OPTN, or the Organ Procurement Transplant Network, was developed in 1984. As a matter of fact, I was the only Black on that transplant task force. And ever since then, UNOS has been the organization that has run the OPTN. Many of you wouldn't know this, but MOTAP and myself protested the concern that Congress had said that the OPTN should be run by a profit organization. I protested along with Nancy Ashley, who was, there's only 4 members of the original task force were still alive. And only 2 of us were able to respond, myself and Nancy Ashley, And we argued that the OPTN should be run by a non-profit organization. And the Congress was not receptive to it, but we also met with HRSA. And we also sent letters to HRSA and Congress of the United States. And as a consequence, the OPTN remains nonprofit. All the rest of it is going to be contracted out. But the OPTN, which will be the board that runs the whole OPTN organization, the board of directors, will be run by a nonprofit, which is something that we fought for and actually were successful in accomplishing. So, but that means that the rest of the issues will be contracted out, probably to profit organizations that will be new vendors. So it's an interesting revolution in transplantation occurring because there are a number of people who felt that the UNOS running the OPTN for the last 40 years and the Academy of Sciences, Engineering, and Medicine felt that transplantation was not equitable, and because of those shortcomings, felt it needed to be completely taken over again. And as a consequence, this OPTN modernization is what occurred. And it's the first time in 40 years that UNOS has not run the OPTN. Any questions or comments about this revolution that's taking place? Many of you may not understand its significance because, as you know, nearly 60% of the people who are waiting for transplants are minorities. And we have more than 100,000 people on the transplant waiting list. We only do last year we did 47,000 transplants. So as a consequence of the donor shortage, 17 people die every single day. So it's an issue that is of great importance. And so we have to be involved in this to ensure that our minority population is taken care of. As you know, we have more hypertension, diabetes, and more kidney disease than any other.
So what you're saying, Dr. Calendar, is that the transplant people are still under nonprofit.
Yes, that is the thing that we fought for and actually were successful in accomplishing.
That's good.
Yeah.
I noticed, Doc, the thing that jumped out to me was every 10 minutes, a new person gets added to that transplant wait list.
That's correct.
Every 10 minutes.
Every 10 minutes. Dr. Perez.
I also read an article recently where AI is also undergoing, starting as a nonprofit, using access to resources from the federal government that was to benefit everybody. And now it's turning commercial. And therefore, what will drive it will be money. And so when we take anything out and make the shareholders the voice of command, we lose.
It's very dangerous. One of the things, though, that is interesting, I just reviewed a paper confidentially that in which AI is being used to improve the bone marrow transplantation capacity for people of minority, because one person who is a minority, actually who is an AI expert, actually required a bone marrow transplant, got it successfully, and realized that odds were stacked against minorities, and as such, they've moved to make AI a way of overcoming the disadvantage that minorities who are candidates for bone marrow transplantation face. But your point is well taken, that when you have nonprofits that are really concerned about people, you're better off than to have profiteers who are only concerned about the dollar. Okay, thank you. Any other comments or questions? If not, one of the next article you have is to stay up to date on vaccines, and this is important because now we have 3 vaccines. We have the COVID, the flu, and the RSV, which we never had before. And the RSV is the one that affects people who are older than 50, and especially those who are 75 and older, and those who are very young. So it's important to remember that Medicare coverage covers vaccines for all of the things that we're talking about. The respiratory vaccines, the shingles, the tetanus, the diphtheria, whooping cough, and all of those things are covered by Medicare. So most of us have no excuse for not getting those vaccines. An ounce of prevention is worth a pound of cure. Any comments or questions?
I had an awareness doc. I just highlighted. It said if you recently had COVID, you can wait 3 months to get the vaccine. And
Thank you. Very good point.
I just had it in July on my way back from the Philippines. So 3 months, let's see, July, August, September, October. October would be 3 months.
Yeah.
So I'm gonna do that.
Good.
My question though, and I think I might have asked you this before, could I get all 3 at once or should I wait?
I think you could take 2. Take the COVID and the flu, but take the RSV separately.
Okay.
That's
And
my advice, because some people who've tried the 3 have had problems.
okay. And we have to ask for the
For the
higher
flu vaccine, you should ask for the double potency. Yes, if you're over 65.
double potency. Okay.
Yeah, if you're over 65.
I'm wondering why they wouldn't give that to me automatically. Why I would have to ask for it from Kaiser? Wouldn't
I can't speak for Kaiser, so all I know is that other people who get the vaccine independently and they go to the China pharmacies, if they don't emphasize that they're over 65, they may not get the double potency dose.
All righty.
Maybe they cannot assume that you're over 65 because you will get insulted.
Yeah, maybe, could well be. Rather than excited that you're over 65, right?
How much time should you wait after you get the RSV shot before you go back and get the others?
Another week.
Another week.
Week or so, at least a week.
Yeah, and a question also I wanted to ask. My husband and I both got the RSV, and I was perfectly healthy, I thought, but I came down with a head cold after I got the shot. Do you think it had anything to do with the shot?
It may have. You never know. You know, RSV is brand new, and let's see, just came out last year, so haven't heard any reports about it. But you never know. Never know.
Dr. Calendar, I noticed that the this article is saying that if those who have had COVID can wait 3 months. What happens if you don't wait 3 months?
Oh, no, but then it's just that you have immunity up to 3 months after you get COVID. So when you wait longer than that, you're vulnerable. That's all.
Okay, thank you.
That's all it means.
Yeah, I've got a comment back to the shingles vaccine. I read that the Shingrix, the vaccine for shingles, lasts 7 years, so that you have to get another vaccine after 7 years.
Thank you for sharing. Good. Jochebed?
Doc, Dr. Calendar, uh, the young lady who just spoke about the RSVP. Um, um, I took the RSV and I think flu. Yeah, the flu, the double dose, double strength flu back in July. Went to the convention and came back from the convention and had what I thought was a cold. Um, just no symptoms other than a runny nose. And I also checked myself for COVID. I during all of this time of COVID, I had nothing. I never got it, thank God. Got all the shots and everything. But I became positive. That was the end of July. And then I was told I was scheduled to take the uh, COVID vaccine later on. But I found out about 3 month wait after you test positive. I had no other symptoms, but I did test positive. And I don't know if it had any bearings on RSV or if it was the convention.
Okay, well, convention is more likely, but the 3 month wait is advisable.
Hmm.
Yeah. Okay, thanks for sharing that.
Mhm.
Any other
Uh,
comments?
yeah, this article doesn't cover pneumonia vaccinations, but I'm reading that 1 to 3 doses will last for the rest of your life for the pneumonia vaccine. One dose if you don't have immune system disorders and you're a non-smoker. Possibly another couple of doses, if recommended by your doctor, if you have immune system disorders or you're a smoker.
And it's also important to recommend to appreciate that with the pneumococcal vaccine, actually 2 shots are recommended. Unless you've already had one of the vaccines previously, in which case the new vaccine, maybe only 1 dose of that would be adequate if you've already had the pneumococcal vaccine. But the new pneumococcal vaccine actually has more, prevents more pneumonias than the previous one.
Okay, so
Thanks for sharing.
I had my pneumonia vaccine last year, and there's a newer one from last year.
Well, actually, it came out. I think it was this year that it came out. Uh, do you know? For example, there's a special pneumococcal vaccine that came out. I think it was this year. That is has about 23 uh, bacteria that it protects against, in contradistinction to the previous one. So, if you had that prior to this year, I think it's recommended that you get the updated pneumococcal, which you would only need 1 shot of that.
Okay, but there's no bad effects of having the new one
I
for
don't
this
know.
year.
No, I
All
don't
right.
know any bad side effects of the pneumococcal vaccine.
All right.
Any other comments or questions? It's very important timing to talk about this because the flu season really starts in November. So doing what we can before November is important. Okay, let's go to the next one. Very timely presentation.
This is the next one, Doc.
Oh, this is the next one. Okay. Yeah, the RSV testing and vaccination in adults. And this talks about how RSV differs from the flu and from COVID and how it's transmitted. And talks the importance of washing your hands and how RSV starts off as a runny nose, as talked about, and as Betty talked about, and so that. But if that's all you get from it, then of course you're wonderful. The problem is that that's just the beginning of things. If it's RSV and you're not vaccinated, and that can quickly turn into pneumonia and bronchitis and wheezing and difficulty breathing and other pneumonias, particularly in people who are of old age. And while RSV differs in that it's how it's transmitted, fomites also and what you touch becomes important. So washing your hands becomes as important as wearing masks and things like that. So I think it's very important that RSV is very different, but is particularly lethal in older people and younger people and children. Yes. The fever that goes along with it, and the shortness of breath, and hypoxia is what hypoxia means, that the oxygen level is low. It makes it more dangerous for older people, and particularly if you already have problems like chronic obstructive lung disease or other things. So. Any other comments about this? It's good timing for this because we're getting upon November is just a month away.
I guess the only other comment is how important it is for us to remember as we are becoming more and more mature, that our exposure to the little people and what they bring, if
That's
we
true.
want to be with them, we really need to be serious about our vaccination, because they bring all kinds of stuff.
Well spoken. Well spoken. We love our little ones, but our little ones give us many things, heartaches and other things. Carol?
Yes. When we had young children, we relied upon the pediatrician very much to keep us abreast about what vaccinations they need. As we're older, it should be our primary care to keep us abreast, because it's a hard time keeping a list of what, and the people that do not see their primary care but once a year. Is there a way how we get it out to the public of what vaccinations you have, or it's just people that have primary care?
Well, I think everybody should keep up with the vaccinations. Those with primary care doctors certainly have it easier, but I think it's your responsibility, as well as the primary care doctor's responsibility, to know what vaccines you have, because otherwise there's no repository. Now, if you make that one of your own responsibilities, you and your doctor together can make sure that you're protected.
Yeah, I noticed like CVS or maybe Walgreens, they are sort of vigilant, especially people that come in for medication, of keeping you aware. And I was just thinking, in our society, what is keeping our society aware of what vaccinations they need now.
Yeah, and I think it's up to you. And if you have a primary doctor, then you have an advantage. But I think you should accept it as your responsibility to keep up with your vaccinations. Dr. Perez, what are your thoughts?
I think it's our responsibility as as disciples of Dr. Calendar that we spread the word and that we make sure that these are discussions that we have with our peers, because vaccinations was not a moneymaker before COVID. and, and so it's, they're coming out, their brand name. If you get Syndrix, you're now associating a special vaccine with a company, a brand name.
Right.
And that didn't happen before. So it's especially important for us as mature adults that we speak about this new public health education to our peers, because they're missing out on it. And many of my peers are not digitally, they're digitally challenged. So a lot of information that's coming from social media, they're not getting. And we don't gather like we used to gather. So, just as we're saying, hi, how you doing? How's the family? Did you get vaccinated? Because for our children, you had to have that little vaccination card to register them for school. So we now have to build another system so that we educate ourselves and elevate our community.
Thank you very much. I agree with you. Tatum, your hand is up. John?
Yes, I was going to mention that another difficulty is you have people with weak immune systems hanging with people who have strong immune systems. I'm talking about grandparents and grandchildren, but the teachers have it even worse, because as far as hanging around people who have strong immune systems, they're teaching school and they're around, hundreds of kids, during recess, et cetera, et cetera. So that's something to be concerned about. Hanging with, if you're elderly, how much you hang around with the youth is important to watch out for.
Thank you. Thank you. John Buchanan?
I don't know if anybody else has this feeling, but some people, especially when I'm in a mixed group, quote unquote, a mixed group of people, may have a tendency to be offended if you ask them about vaccinations. You know what I mean? Especially the ones who don't believe in vaccination. Some people say, I ain't getting no vaccination. They have a very negative view of vaccinations, period. So,
Yeah,
but
okay. Well,
I still ask them, but some of them do get offended.
Yeah, you're right. They do. Lucy, you want to speak again?
When I was a little girl, my aunties never said the word cancer. They whispered it.
Right.
That ignorance has killed us. So get offended. Get offended. When the light is turned on, you can no longer curse the darkness. We can't accept it.
Good discussion. Good discussion. Thank you.
Just one more point. This session has helped me. Last week we were talking about sex, and do we inform our children or our grandchildren? So I just mentioned it to my adult children. Have they had their talk with their children? And the response was yes, except for, I asked the fathers, had they talked to their sons, and the mothers to their daughters. And they just didn't know. They said yes, except for one, and they just didn't know how to approach it because they didn't know how young you were supposed to start it. But like Dr. Perez says, we start with our family, and whether it's offensive or not, and the people that are around us, people tend to listen to you if they hear it more than once. So if we just mention it, start with our own small circle, and it'll grow out from there.
Wow. Powerful. Powerful.
Amen. Amen.
Okay. Wow. What a group we have here, huh? My goodness. Now this is something that one of our group members brought up last week, that they have a approved nasal spray as the first self-administered flu vaccine, which will not be available until next year. But it's interesting. We're moving away from having everything done by doctors and pharmacies, getting to the point that we're even giving vaccines to ourselves. So, and this is nasal spray. So whether that's going to work or not, we'll find out next year. It's not this year though, so don't go looking for it. It's likely to be available as of next year. Look at these figures. I think these figures at the bottom are important to realize that 100,000 people were hospitalized, and between 5 and 51,000 people died as a result of the flu. So it's a dangerous disease, particularly for those of us who are aged. The elderly people like me and the seniors like you.
Dr.
Do you know
Calvin.
if the nasal vaccine is as effective as a shot?
Well, that's something we'll find out next year. That's the question that I would have, and that they didn't say, but if FDA proves it, we need to have more data before
That
we.
was sort of my question too. Were they going to have the high dose for older people?
I don't know, and
Right.
so we'll know more when it gets closer to next year. John Buchanan.
My question, is there a possibility of somebody taking too much?
I don't know the answer to any of those questions. As we get closer to next year, we'll find out. Now it's just an alert that it's going to be available. Again, AstraZeneca is the leading the charge on this. We have information, but no answers to any of the questions that you would ask yet. This is an article that says that the new shingles vaccine is tied to a lower dementia risk. And I always take this with a grain of salt because we're still a little bit unclear on what actually is causing the dementia. We have some ideas and thoughts, but have not come up with any treatment for it that works reliably. So, but anyway, the fact that taking the vaccine is tied to lower dementia risk has a positive sense in that if more people get the zoster vaccine, Shingrix, then wonderful. So, but anyway, they looked at the data and have concluded that there's a lower dementia risk. This just came out in the journal this year. So time will tell whether this will hold up, but the initial data results say that the vaccine is associated with a lower dementia risk. I'm not sold on it, but time will tell. I think we'd be better off if we had a better idea of a treatment for dementia, of the dementia that when they talk about dementia, 80% of the dementias are Alzheimer's, and 20% of dementias are other causes of dementia. Isn't that interesting? In the United Kingdom, 60% have shingles, whereas the United States only a third. So we got a long way to go. And there's an article in the Washington Post. Those people who had shingles say that the pain associated with shingles is equivalent to that of childbirth. So you can understand. And that on a scale of 1 to 10, it's at a 10 and on a par with childbirth.
That difference in vaccination rates could be because Medicare Part D just started making shingles vaccines free in January 23. United Kingdom may have had a free vaccine before that date.
Yeah, maybe. Okay. Thanks. Thanks, Darryl. Okay.
Be covered as opposed to free.
Right. Medicare covered.
Right. Nothing is free.
Which brings up another issue, because for the uninsured nowadays, vaccinations are not free.
Mhm.
So the uninsured have a problem and may not get vaccinated. Those, of course, who are insured, they can get it. But last year, COVID was free. This year, COVID is not free. And if you have Medicare coverage, it's covered. If you are uninsured, then you have to pay out of pocket. This is another epidemic. We recognized last year that loneliness was an epidemic, and that it was a public health concern. This is an article that recognized how important it is and how they have identified a way of educating, making people aware of it, and also action of going forward and trying to recognize that loneliness should be done away with. That's one of the things. And social interactions are essential for human beings. And this then, they have done the analysis and got the data to back up what we have always known, and that is the interaction of one human with another is very vital. Just in contrary to what happens with the social media, where you don't have the social contact, you have the antithesis of that. And then, of course, this with a combination of mental activity and physical activity allows for one to live a more normal life. Whereas with loneliness, the likelihood of depression and suicide and cardiovascular disease is very closely linked. Any other comments about this issue that we are well aware of? And as a matter of fact, this group is in some ways responsive to the fact that social isolation does not help but harms. Betty?
So I should I should really be happy that my grandchildren bug me all the time about doing things.
Yes,
So
yes. You should be thrilled. John Tatum.
Yeah, I was misled by the title of this article. At first, I thought there was a medicine that you could take to cure loneliness, but I said, how are they going to do that?
Not quite. Not quite. Okay, the medicine is join a group, interact with others, and as Betty said, be responsive to your children and grandchildren. That's the medicine.
Mhm.
And there's so many of our babies that need
Yeah.
be the unpaid Uber driver.
it. Yep, or just being able to cry on your shoulder, or you know, our our young people are really suffering.
Yes. It, and I'm wondering, I was sitting here wondering if technology isn't taking over so much, because you see people at restaurants or at a game even, and they're looking down at their device. And so there's no socialization beside the person that's sitting right beside you. You're not having any kind of conversation and stuff. You're just looking down at your device.
I've
It's,
seen the boy and girl together, and they're both on their own social
yeah,
media, and they're not talking to each other. That's
right.
it's tough. It's tough. John
I,
Buchanan.
Yeah, I noticed this years ago when the cell phones first came out. I looked at an intersection where there was a traffic light and pedestrians were waiting at the corner to cross. And if there were 10 pedestrians waiting to cross, 8 of them were on a cell phone, and
Hmm.
nobody was talking to each other.
Right, right.
I agree with that. It's and especially now with the kids on the video games,
Yes.
they're totally disconnected from the rest of the world.
Yeah, and whenever you see them on the airplane, that's exactly how it is. Yeah.
I also think our society, the more money we have, the more isolation we have. Um, when we had children, it used to be the time when you had a family, all the children were in one room. And they might have 8 children, 3 bedrooms, but the children were together. Now, the ideal thing is every child has their own room. That starts
Mhm.
isolation. Then
Right.
it was several generations living in a home together, and they helped each other out, where grandparents live with their children. And sometimes when children or young adults start out, they lived at home, and now people are complaining that their young adults are living at home. But that's a time of socialization where generations need to be together. Now parents and children are living all over the country, so grandparents see their children once a year, maybe. We have grown so diverse, and we look down upon the cultures like Hispanics and etc. that are living there together. I bet their loneliness is not half as great as our generation that and our culture where people are all in a separate room even to sleep. So we are creating this loneliness among our society as we grow richer and everybody has their own private space.
Mm.
So true. John, you had your hand up again, or
Yeah,
okay?
I had a comment for John and then a comment for Carol. John's comment first, he said those people at the stoplight. 8 of them were on their cell phones and 2 of them weren't. I would be concerned that, a lot of times people are on their devices and, could get hit by a car, if they're
Yeah,
not careful.
that's what's
Mhm.
happening.
Yeah.
That's exactly what's happening.
And my
Yeah.
comment to Carol is, I knew of a family where 9 people were sleeping in one bedroom. And so Carol, do you think that's going a little bit too far?
Yeah, there. Yeah. But I bet nobody was lonely.
Uh,
I actually saw somebody walk into a lamppost while they're on the phone.
well, what is really bad is that the drivers are looking at their cell phone. And that's when people have been killed because the
Yes.
drivers are looking at their cell phones and they run over pedestrians.
I think getting killed by a car is up in the top 3 of the deaths in the country. Is that correct? Being hit by a car.
It's among the top, and it's a problem that is related to people being distracted while driving.
Mhm.
And this is another example of distraction. Any
So
other
it's great to point fingers, but what about us? How can we start as individuals as far as this loneliness? What
Well-
can we do for ourselves and our families?
Well, I think let's hear some thoughts on that. I'm sure that some of you have ideas as to how we can become more socially. We can invite people to church, for example. We can invite people to communicate with us, or we can call people, call our friends. Betty, let's hear what you have to say.
Yes, you can call your friends. You can also have more family gatherings. Celebrate your birthdays and different things. We try to do that in our family. But then you can just have, I go to a senior building twice a month to some of my old friends just to play Pacino.
Good, good,
Mhm.
Just
good.
think of different things to get you together. And of course, my husband definitely say I stay on the phone too much.
Any other comments? John, you want another comment? John Tatum? No, I guess he's not. Okay. Any other comment about this? If not, Lucy?
I was going to say also, even just starting conversations on a grocery line, you're on the line. I've now, when I'm not in a rush, and I'm trying not to be in a rush as much as I used to be.
Okay. Any other comments? Okay, if not, we'll move to the next issue. This is an interesting perspective on mammography at the age of 40, because you may have false positives. And many are concerned about the false positives. Actually, what they mean is that you may find out conditions that are not cancers. That doesn't bother me. But I'd rather find out that I've got a condition that's not cancer than to have cancer and have it missed. But anyway, so this is legitimate concern that you may have false positives. But the question is, would you rather have a false positive or miss a cancer? And so that's the alternative. What are your thoughts about that? Which would you rather have, the false positive or miss an early cancer? Betty, your hand's still up from before? Or?
No, in respect to this particular article, I just recently had a mammogram. And when I went in, they asked me if they have something new, I think that is more dense or something
Yes.
more that they do. So
Yes.
they asked me, they said it wasn't covered by my insurance, and they asked me if I wanted to do it. So it was only $40. So I said, okay. So I got a letter back telling me that they had found something, but when I looked on my profile, because everything is on the online now. So I looked on my profile, and the only thing that it said was that my breasts were not dense. So I don't know. They told me to check with my primary care physician, but if they sent the thing to my primary care physician, if it was anything that I should be concerned about, I'm sure she would have called. So
Well,
I
I think you should call her.
yeah. So
Yeah, you
when
should call her and ask her opinion. Don't
okay.
don't presume that she would call you because
Yeah.
she may miss it. And so I would call her and let her know that exactly what you found and ask her what her opinion is. Any other comment on this article? Because it's a legitimate concern that you may have breast issues that are not cancer that may be revealed, and you may have surgery that is necessary for that. What are your thoughts, many of you women who have mammographies? What are your thoughts about continuing this, getting mammography after the age of 40? Because some people have breast masses who are younger than 40, and they have mammograms, and they also have to have surgeries, which are for diseases other than cancer.
Dr.
The
Calendar,
the National Medical Association significantly pushed to reduce the age for mammography to women. I think it started off around 50, brought it down to 45. Strong advocate that we move forward in that direction.
Carol, was your hand up?
yes. So what you're saying is a false negative means they're telling you that you got cancer or you don't have cancer.
No.
Which one does it?
False positive means that you have something, but it is not cancer. But false negative means you missed it. It was there and you
Okay.
missed it.
So they're reporting to you that you have something, but it's not cancer.
That's correct. That's
So
a false.
what's the problem?
It might be an abscess. It might be mastitis. It might be a tumor that is not a cancer. Those are things that if you find them, they need to be removed as well. But they're not cancers. And so the question is, does this cause concern? In other words, do you think, therefore, that the getting mammographies before the age of 50 is desirable or undesirable? That's what they're asking you. And I think, as Dr. Perez has pointed out, the NMA lowered it because there are a number of people of color who develop breast cancer at a younger age than 50, and they would be missed completely. And so then the question is the fact that they have false positives and they have diseases that are picked up that are not cancers, does that negate the value of the mammography? And that is the salient issue of the day. Any
Well, I
comments?
think that's wonderful. You pick up something that I didn't know I had, and there's a way, and it's not cancer. Yes, I would love that. I was looking forward to the day where I got too old to have one. But
Well, they're not recommending them after the age of 70.
I know I told my doctor that, and then he looked at me like, well, it's best to do it anyway. And I'm looking at him. Yeah.
Well,
I said, can I take a break? So, but Betty, you're encouraging me. You still doing it. Okay.
Yeah, well, that my doctor told me to, but I was hoping this was the last one.
I know I was hoping it was my last one. Oh,
Dr. Perez?
My sister-in-law had breast cancer at 82.
Your sister-in-law had to say again?
My sister-in-law was diagnosed with breast cancer at 82. Whenever we can shine the spotlight on us, we are worth it. Screen, screen, screen.
Okay. Pearl? Can't hear you. Can't hear you. Can't hear you. We cannot hear you. We can't. Can you tell her we can't hear her? She's on mute.
Can you hear me now?
Yes, we can hear you now.
Okay, well, as most of you know, I just recently turned 86. And my doctor has been recommending that I have mammograms probably every 2 or 3 years. And I think I had my last one last year. So I would recommend that everyone continue to have them. I mean, I know they're uncomfortable, but what's a little uncomfort if you're trying to stay healthy?
Thank you for sharing. Dr. Perez, your hand's still up. You have something else to say?
No, I'll lower it.
Okay.
Dr. Calendar, the other thing too is when you get the false positive, there is a schedule. There should be a schedule when you should go back and check and see if what you saw is going to turn into anything worse.
Well, the way you do that is by getting a biopsy. And so that's what they're talking about. Some would consider getting a biopsy to find out whether it's a tumor that is not cancer or whether it's an infection or inflammation or something else is worse than the cancer itself. We know that many of the diseases of the breast are benign. And so if it's benign, that means it's not going to be a cancer, but infections require treatment as well.
So you say the biopsy should be taken at that time, or can you wait?
If you have a lump that is not a cancer, most doctors would feel that that lump should be removed because the only way you can prove it's not a cancer is by taking it out in biopsy.
Thank you. That answers my question.
What do men do? I mean,
Men do
unless
nothing.
they have
Men do nothing because unless they have a abnormality in the breast, they do not need to be screened because breast cancer is very uncommon in men. But if they have any enlargement of the breast, then they need a mammogram as well.
Mhm, mhm. I do know of a person who was diagnosed as having a cancerous cyst in the breast.
Yes.
Yeah.
Breast cancer occurs in men as well and requires the same treatment as in women. Carl, was your hand up?
yeah, but Jacobet took my question because I was wondering about men. How come they don't have to go through that? I
Because
think they went through that, they would invent, which they're trying to do, invent a newer technology where it's not as uncomfortable.
well, it's interesting. I raised that question to the female radiologist, and they said they have not identified any technique that is not associated with being uncomfortable. But because breast cancer is so rare, so unusual in men, there's no, it is not recommended. Screening is not recommended for males. But if you have any symptomatology, increase in size or mass or anything like that, then a mammography is recommended.
Carol, you must have forgotten. I had a mammography because I felt something in my breast area. And after my mammography, it turned out to be nothing. However, I'm thinking, and I could be very wrong, the differences between if you have large breasts, the exam hurts more than if your breasts are real small.
I have no answer to that question. Betty, you have a comment? And I saw Genesis.
Yes, a male having a mammography would be a lot different than a woman having one, because they couldn't have one the way we have one, so they have to have some other technique.
Well, it's just that it depends on the size of your breast, as John said. So because we have small breasts, the likelihood of it being as uncomfortable as it is for women, because you have large breasts compared to what we have, is not as uncomfortable for the male as it is for the woman.
I can't see a male breast getting smashed like ours.
That's because it's smaller, so it's not going to be smashed like yours.
Okay.
And that's why it's the screening process is not essential for men.
Okay.
Any other comments or questions, Janice?
No, I was going to say the same thing Betty said about the smashing.
Yeah.
Male breast is smaller. So I don't know, maybe some truth to that, but very uncomfortable. But sometimes it depends on the person administering the exam, because I have had some where you barely felt it at all. And I think recent years, the techniques have gotten a little better. So I guess it depends. It's not all the same.
I can tell you that mine did not hurt. It wasn't even anything worse than me bumping into a wall or something. That mine wasn't bad at all.
Okay. Any other comments? If not, we'll move to the next article.
All I'm saying is they just need a woman to do research for a better technique, because men are really not interested because it doesn't bother them. But I bet you if it bothered a man, if they would have that technique really down to a T.
Don't agree, but reasonable people may differ, because women are just as interested. There are women radiologists as well who are aware that the technique is associated with discomfort, so that it's not that they're blind to it, it's that they have not come up with a technique that does away with the discomfort. Now,
But I have to support you there. Now that we have more diversity and inclusion of women making decisions and allocating resources towards that research in comfort, we will begin to see a change.
Well, many of the radiologists now are women, so you have the diversity that you're seeking. So time will tell, but I continually raise that issue so that they will try to do better, because it's still a very uncomfortable procedure. Cancer risk, pesticides, the new smoking. And of course, the answer is that pesticides are with us, and yes, they are associated with cancers. And in many ways, because of the association with lymphomas and pancreatic cancers as well, many people consider pesticides that are put in our food as one of the reasons why we have so much cancer. And I think data is accumulating to support that philosophy. As I think Darryl has mentioned time after time, that the pesticides are one of the reasons. Of course, we know there are other things other than the pesticide now. As we know, we're involved with all kinds of chemicals that are in plastics and all other things. So pesticides, along with other man-made products, are increasing our risk of cancer. And in many ways, they are the equivalent of the new smoking. So I don't think there's any question that, yes, pesticides are among the reasons why the cancer risk is increased. Any comments about this concept?
Yeah, my comment is that if you want to avoid pesticides, you have to eat organic. And organic produce, still wash it, but that's the only way you're going to avoid pesticides. There's a couple of other additives for meat products. Okay, you got to consider if you're eating conventional meat, then they're being fed grain that has pesticides. That means it's conventional. Organic, they're eating grain with no pesticides. Also, for meats, generally in America, meats are injected with growth hormone and antibiotics. And both of those are, it's kind of a trifecta that works against you: the pesticides, growth hormones, and antibiotics, which could make you antibiotic resistant. And so that's, if you're going to eat meat, you need to eat it organic and grass fed.
Thank you for sharing, Darryl. Any
welcome.
other comments or questions? Yeah, John Buchanan.
Yeah, my only problem with organic is that you have to almost live in the grocery store because it doesn't last very long before it gets old on it. So, you have if you get it, you almost have to eat it right away. Organic.
Well, as I said before, okay, it may not last long, so eat conventional and you won't last long.
Thank you, Darryl. On that positive note, Betty.
Do they put pesticides and stuff on grass? I heard you say grass fed, but don't they do something with the grass too?
If it's organic meat that's grass fed, so that's beef, cattle, chicken, beef, pork, and chicken. If it's organic, then there's no pesticides on the grass.
That's what they say.
Okay. Any other, Janice?
Well, just one more comment about grass.
Okay.
Grass is a natural diet for cows and chickens. Corn is what they're fed. That's not their natural diet. It makes them sick, and so they give them antibiotics.
Okay, Janice, you had a comment?
No, no.
Okay.
Bring it on
the
this side. Table. Can you bring the table on this side?
Did you have a comment, John Tatum?
No, sorry.
Okay. This is the article on the new screening tests for blood test screen for colorectal cancer. And a lot of commentary about it, but it is probably it's a new test that is for people who could not or would not accept the colonoscopy, which is probably the best way of diagnosing pre-malignant changes that will develop into cancers. So this screening only finds if you have cancer, whereas the colonoscopy identifies precancerous lesions and removes them before they become cancer. So it is probably the least effective way of screening because it is only looking for cancer. And so colonoscopy remains the gold standard because it identifies lesions that are precancerous that will turn into cancers over time. Whereas this blood test is the least effective of the screenings because it picks up cancers. So we still think that the best screening for colorectal cancer is a colonoscopy. Although the other modalities pick up whether you have bleeding or not, which can be associated with polyps that have not turned into cancers yet. But once the cancer is identified, it has to be removed. So the pro is that if you cannot get a colonoscopy, which is the best screening procedure, this blood test is better than nothing, I guess you could say, because it can pick up an early cancer. And with that early cancer, you're still going to need a colonoscopy to find out where it is and decide how to best treat it. Betty, your hands up.
It's still is it still recommended that people in our age group or 80 or so over don't need to have a colonoscopy anymore?
Yeah, there's still a debate about it, but most say that the risk, unless you have a family history of cancer, if you have a family history of colorectal cancer, then you have to weigh the cost versus benefit ratio, meaning that if you're 80 and in good health, colonoscopy may be recommended. If you're 80 and you have many comorbidities, and if you're frail, then then you and your doctor have a discussion as to whether you should have it or not. But if you're 80 in good health with no comorbidities, it is thought that colonoscopy can be beneficial every 10 years or so. Because older people do develop colorectal cancer. Any other comments about this very interesting topic that still will lend itself to much discussion and much debate with your doctor about what should be the next step for you, taking your age into consideration?
Dr. Callen, I had a question. They also have those mail-in tests.
Yes.
Colon cancer. So when we talked about that on this group session, we were saying that one's okay. I mean, you said then that the gold standard was still the colonoscopy, but you did say that if you wanted to, just really, really be sure, you just do the colonoscopy. But these other tests, like the one we're talking about today, the blood test and this take-home test, do those only if if you haven't had if you've had one recently and you just want to do a double check.
Well, the difference is that the blood test is for cancer, whereas the other tests that you're talking about are to find out if you have blood in the stool. And there's a new test that the test that they're talking about is also for cancer. But many of the other tests that you're talking about are just to find out if you have blood in your bowel movement, which can occur if you have a precancerous lesion as well. So there's merit to all of those screening tests. It's just that the one that is the gold standard is the colonoscopy. Does that address your comment? Okay, no comment means no comment. Okay. This is an article that talks about why the FDA has not talked about banning hair products that use formaldehyde, which are thought to be carcinogenics. And hair straightening products often have formaldehyde in them. The FDA has never decided that they were banned. And in October, they did propose a ban, but it still hasn't come to pass. And so this article talks about the hazards of formaldehyde and that it is a known carcinogen. And so while there's a minimal amount of formaldehyde in hair products, there still is people who feel strongly that, of course, we had many discussions about straightening hair and all that stuff. And well, people still get hair straightened, but the fact is that formaldehyde is a carcinogen. Dr. Perez?
I meant to lower my hand, but I think again, greed. If the FDA put a ban on it, there would be a class action for Black women and hair straightening products because they knew, they still know.
Okay. Well, any other comment? Okay, so
Yeah, my comment is that we need some retraining. Well, okay, not retraining. We never had the training. Black hair is not appreciated. We try to groom it like white hair. Like, okay, our hair is flat. If you look at it under a microscope, which means that it coils. You know, to different degrees, you can be very kinky, you could be curly, but how you what you do to our hair is entirely different. You know, we base all of our grooming on what white hair should look like, and you know, like a little kid, mommy, don't comb my hair, it hurts. Well, if it
right.
hurts, don't do it. Our hair, kinky hair, is not designed to be combed. Our hair should be groomed entirely different than white hair. And there's some advantages of our hair that we're completely unaware of. Um, you know, it's like human beings are very strange animals on this earth. We're the only ones that have to wear clothes. The rest of the animals are from around here. Well, we're obviously not from around here. The other thing strange about most animals don't have to go to the barber. You know, a sheep, okay, you can shear a sheep, you know, like we have typical Black person's hair is wool like hair like sheep's wool.
Yeah.
And that wool on a sheep can be very, very thick. But we breed sheep for their hair to grow the hair very long. But sheep that aren't bred that way never have to get their hair cut. And my point is, having hair like sheep's wool means that unless you do some things to straighten it, and combing and brushing is a physical way of straightening it. With black hair, if it's kinky, you never have to get a haircut. You never have to shave. You know, there's some reasons why white folks shave, the men shave, and that's because in hot and cold, having straight hair on your face is uncomfortable. It doesn't wick the water. The hair, a beard stays wetter, either in cold or in heat, and it's uncomfortable. They have to shave it. A bearded Black man with kinky hair can be comfortable. You don't have to go through the process of, you know, it's a process of shaving. And you're putting different emollients, uh, a lot of petroleum products on your face just to make a smooth shave, which are toxic. So, you know, I could go on and on about the advantages of having black hair that we don't appreciate and realize those advantages of having black hair.
Any other comment?
I I hear what you're saying, Darryl, but you know, as Black people, we weren't brought up that way, and we're used to combing our hair, and if you can't get a comb through your hair, you tend to do something else with it. So I'm not ready to be bald, so I can't get a comb through my hair unless I do something else with it. So I have been doing something else with it since I was about 16 or 17. When then my mother did something else with it before that. She used a straightening comb. So it's kind of hard at this stage of the game to change.
Any other comment? This very, very interesting subject. I know as a Black male with kinky hair, it was kind of nice to lose my hair because I don't have to comb it. But but Darryl's points are cogent and interesting, and we all understand the validity of his comments. Any other comment?
Well, I see a lot of our people seemingly I know they use products of some kind on their hair to make it look kinky. These braids and whatever else they call it and so forth. I grew up as Betty, my grandma used to plait my hair. She'd comb and brush it until it was shining, and then plait my hair. And I'm wondering if some of the braids that some people are getting isn't with that idea in mind. It keeps it from being kinky. But I like wearing my hair natural. Whatever way it comes out, that's the way it is.
Any other
Well,
comment?
here's something nasty to share, and I probably shouldn't. But I started wearing my beard in 2011. And that's the last time I shampooed my hair on my head or my beard. I stand under the shower and I rinse out the dirt. The thing about straight hair, white people's hair, it's oilier and they have to shampoo to get the oil out. That's one of the advantages of being black is that, okay, my hair doesn't smell. My head doesn't itch. We put all these products in our hair and we have to shampoo them out. The good Lord built us to be shampoo free. We don't need it.
Okay, thank you. And Burr, you have some comments?
Well, I just wanted to comment about the natural hair a bit. Since I've started wearing this hairstyle, I have not been happy. It does not it does not take a lot of work. In fact, I tell all my friends that I now have wash and wear hair. And I mean, it's just, as Betty said, I'm her sister, so I grew up with the same type of hair care that she did. But since I started wearing this style, I would say maybe the last 15 years, it has been great.
Okay, Betty, take that. Okay, we'll move on. Thank you for the discussion. This is an article that brings us home to address the issue that we've been talking about for years now, and that most adults are unaware that they have uncontrolled hypertension. And in over 3,000 adults, over half were unaware they had hypertension, and 3/4 had uncontrolled hypertension, which is one of the things that we do screenings weekly. And one of the biggest problems is the people who are hypertensive are those people who know they're hypertensive, but they don't take their medications, or they don't take the medication to the point of controlling their blood pressure. And many of the studies have demonstrated that cardiovascular illness is the #1 cause of death in the country, because most of the people who have hypertension are uncontrolled. And this study, done on thousands of people, has identified and proven that very point, which fits into all of the global data that demonstrate that cardiovascular disease is the #1 killer. And one of the reasons is because those people who have hypertension, which is many of them, they do not have their high blood pressure controlled. And how do you know it's controlled? Well, if you take your blood pressure at least daily or maybe weekly, and you find that your blood pressure is higher than 130/80, then you know that your blood pressure is not controlled. And whether you're on medication or not, if your blood pressure is not at that level or below, then you have uncontrolled hypertension. And that means that you are at risk for all of the complications that go along with arteriosclerosis and cardiovascular diseases. So the question is, do you have a blood pressure monitor at home? Do you take your blood pressure at home? Do you record it? Are you aware of what it is? Because if you aren't taking your pressure at home, you don't know whether or not your blood pressure is controlled or not. And that is a must. So that if you don't even have a blood pressure monitor, then you don't know whether your blood pressure is controlled or not. Because if it's the only time you get it checked is when you go to the doctor, that's not enough. And this is a situation that is of particular devastation to people of color, because we have 2 to 3 times the hypertension incidence and rate of all other ethnic groups. Any comment about this severe indictment that has been proven against again? Dr. Perez.
As we're planning for the holidays, whether your family members, especially, I'm not going to even say our age, our children, our children, it's a wonderful Christmas present. A sphygmomanometer that could be sent directly from Amazon from you on Christmas Day, and and then have that discussion, over Christmas brunch about sex and, vaccinations and what's your blood pressure. But as Darryl is teaching us, we can change the culture. We can be the change agents. We did it with HIV. We haven't completely accomplished that, but we're who we have been looking for.
Well spoken. So let's do something about it. Talk is cheap. Okay. Any other? Yes.
I know it's off topic. Is there any danger of having low blood pressure?
Very little. And somebody asked me that last week. And this was somebody, oh no, this was a patient who actually blood pressure is so low that they have to get treatments for it. But for example, if you have a blood pressure of 90/60 and it's asymptomatic, that is not associated with any problems. But if you have a pressure that's lower than 90/60, then that is a concern. But for the most part, people who have blood pressures that are lower than 110/70 do not have any problems. There are issues that cause you to have hypotension that will cause problems. For example, we have a condition called shock. When you have a pressure lower than 90/60, that means that your body parts are not being circulated adequately. So that, yes, there are problems associated with low blood pressure, but usually they are associated with things that cause you to lose blood or lose fluids, because you're going to be dehydrated. You can have hypotension, which is a blood pressure less than 90/60. But people who have blood pressure of 90/60 and who are asymptomatic usually have no additional concerns.
So would medication that you take for high blood pressure, could it act to lower your blood pressure too low?
Yes, and that's why you have to monitor your blood pressure, because if it gets lower than 90/60, you need to stop it or take it less often than before, because you want your pressure to be higher than 90/60, but not to be symptomatic. And so the desire is to be higher than 90/60.
Dr. Callender, what if you, in order to control your high blood pressure, you have to take so much medicine that it causes you to be dizzy? What can be done about that?
Well, you need to modify that. Then you and your doctor need to work to get your blood pressure to the point that you're not hypotensive, because being lower than 90/60 means that the circulation to the body parts is not adequate. And so you have to have the happy medium, so that, yes, you need to have that balance so that you're not hypotensive, which is less than 90/60, but that you're in a range that is associated with no symptoms and with no complications.
My question has to do with the dizziness that is associated with the amount of blood pressure that you have to take
You
in
should
order.
not be dizzy. If you're dizzy, then you're on too much hypertensive medication, and you need to modify that with your doctor so that you're not dizzy. Because dizzy means that your pressure is so low that you get dizzy. So that's a sign that you need to modify your medication so you're not dizzy. So being dizzy is not positive.
Okay,
Yeah,
thank you.
I had that same effect standing up
Yes,
from seating, and
that's correct.
my doctor adjusted. He took me
That's,
off of half of one and put me on another one. But I was just looking at my last visit to the doctor. My blood pressure was 112/59.
wonderful,
Oh, that's good. Okay.
wonderful, wonderful, wonderful. John, any other questions? Tatum, any other questions?
Nope, I don't have any more questions. You answered my question.
Okay. Any other? Okay. This is another article that I guess this will be the last one. We're over time. AI excludes heart attack better than specialist criteria. We've discussed the fact that AI plus physicians becomes ideal. And so whatever we can do that has the doctor working with AI makes things better, and might argue makes things best. That AI is not an enemy. AI is a friend, and putting the doctor together with AI is desirable. I think that's the bottom line of it. And yes, there are times when AI plus the doctor gives you the ideal situation, and the combination is desirable. Any other comments about that radical comment? Because I make statements like that, but I make them to be alarming, but also to be futuristic and to prepare you for what is coming. Any comments about that radical statement I just made?
I'm gonna call CNN.
That's the future. That's the AI and the physician together, radiology, all of them together. They make for the best medicine.
It's good to know that AI is useful rather than
Yes.
what we hear so much from the media.
Well, one of the things is for us to recognize that AI has its own biases that are put in by the people who are racist. And so we have to have AI that is unbiased. And we have to make sure that all of the data that goes in is unbiased. And until that's the case, AI can be problematic, but we have to work to make sure that the balance is there. Okay, we've had a great group today. And so nice to have so many of you paying attention. Lynette,